Welcome back to The Explainer. Today, we're diving into some incredibly high-stakes biological drama, maintaining the body's delicate internal equilibrium. It's this constant, invisible balancing act of fluids and electrolytes that, honestly, keeps us alive. It keeps the heart beating, keeps the brain firing every single second of the day.
So, to kick things off, let me ask you a question. Where do you think most of your body's water is actually hidden right this very second? Take a guess. Now, this isn't just a fun trivia fact. Understanding this is absolutely crucial. Why? Because vulnerable populations like infants who proportionately have way more easily lost fluid and the elderly who have decreased muscle mass and higher fat are at the absolute highest risk for sudden, dangerous fluid shifts.
Well, here's the reality. A massive 70% of our total body fluid is actually trapped deep inside our cells. That's the intracellular fluid. The remaining 30% makes up the extracellular fluid. That 30% is constantly on the move, navigating the blood vessels as intravascular fluid, bathing the surrounding tissues as interstitial fluid, or filling up specialized transcellular spaces like the cerebral spinal and pleural cavities. It's a busy system.
Here's our clinical roadmap for today's explainer. We're going to cover the foundation of fluids, what happens when the scale tips, the big four electrolytes, and finally, medical management.
Section 1, the foundation of fluids. Let's establish exactly how the human body meticulously tracks all of its water gains and losses. For a body to be perfectly balanced, intake and output have to completely equalize by the end of the day. And there's a really sharp contrast here between our measurable, sensible losses, things like urine, wound drainage, and emesis, which clinical teams can closely track, and our hidden, insensible losses. These are the ones that simply cannot be measured. Think about the vapor you exhale with every breath, or the ambient sweat on your skin. They're invisible, but they matter. Now, what's really fascinating here is the math. 2.2 pounds, or exactly 1 kilogram. That number is absolutely critical. Daily weight monitoring is literally a lifeline for heart failure patients. Because a sudden weight gain of exactly 2.2 pounds, that equals a dangerous retention of 1 extra liter of fluid. It's huge. That's why patients have to use the same scale at the same time of day, wearing the same clothes. Gaining more than 2 pounds in a single day is a massive red flag. It means you call the doctor immediately.
Section 2, when the scale tips. Let's take a look at exactly what happens inside the body when this delicate physiological scale tips completely out of balance. We really need to draw a sharp clinical distinction here. Fluid volume deficit is an isotonic loss, meaning water and solutes are lost in completely equal proportions. It runs the risk of dangerous hypovolemic shock and is typically treated with 0.9% normal saline. Dehydration, on the flip side, involves fluid loss that radically alters electrolytes, leaving the body either hypotonic or hypertonic. And correcting hypertonic dehydration, that requires incredibly slow, meticulously calculated IV drips. We're talking sometimes taking 2 whole days in the ICU. If you try to correct it too fast, water rushes right into the cells and can trigger severe cerebral edema, seizures, or even a coma. And then there's third spacing. This happens when fluid aggressively shifts out of the blood vessels and gets trapped, just stuck, in the tissues or transcellular spaces. It's often triggered by low levels of albumin, which is what normally maintains osmotic pressure in the vessels. Because of this shift, the patient looks heavily swollen from the outside, but inside their blood vessels, they're actually severely dehydrated. So here's the crucial takeaway. Standard diuretics simply will not work here. The patient actually needs IV albumin to forcefully pull that rogue fluid right back into the vascular space where it belongs. Now, heart failure presents the exact opposite problem, fluid volume excess, and the symptoms depend entirely on which side of the heart is failing. Right-sided heart failure means blood backs up from the extremities. This causes systemic swelling, things like jugular vein distension, edema, and ascites in the abdomen. Left-sided failure, though, that means blood backs up directly into the lungs, leading to dangerous crackles and profound shortness of breath. Section 3, the big four electrolytes. Let's introduce the essential elemental characters that dictate all of this internal fluid movement and nerve function: potassium, calcium, sodium, and magnesium. We're going to start with potassium. To remember the normal lab range, just use this catchy mnemonic. Bananas come 3 to 5 in a bunch. And boom, that gives you the 3.5 to 5 normal range. Potassium plays a literal life or death role in cardiac function. In fact, because it so heavily dictates the heart's rhythm, there is an absolute non-negotiable clinical rule. You must never, ever administer potassium via an IV push.
Doing it too rapidly can literally stop a patient's heart in its tracks. What's truly fascinating about potassium is its link to standard myocardial infarction, or heart attack, orders. Because potassium strictly controls cardiac contractions, a condition called hyperkalemia, which is when there's way too much potassium in the blood, can actually trigger the exact same dangerous ST elevations on an EKG as a real STEMI heart attack. It's a massive red flag that demands immediate intervention. Next up is calcium, which maintains our bones, our muscle beats, and our blood clotting, otherwise known as the 3 Bs. Its normal range is 8.6 to 10.5, so just think, call 911 to remember that rough 9 to 11 range. When calcium goes too high, we see what's called bones, groans, stones, and overtones, meaning weak bones, abdominal pain, kidney stones, and hallucinations. But when it drops dangerously low, we see facial twitches like Chavistek sign, wrist spasms like Trousseau sign, and the very real terrifying threat of seizures. Then we have sodium, sitting at a normal range of 135 to 145. Sodium is entirely focused on neurology. Sure, it helps maintain our blood pressure, but more importantly, it dramatically dictates our mental status and orientation. Whether levels swing dangerously high from severe dehydration or plummet way too low from someone drinking way too much water, both of these extremes demand strict seizure precautions and constant, vigilant neurological checks. Rounding out our big four is magnesium, resting safely between 1.3 and 2.3. I absolutely love this clinical analogy. Magnesium is the bodily sheriff maintaining law and order in the muscles, heart, and reflexes. When there is too much magnesium, the sheriff has locked everything down. The whole system becomes dangerously depressed, with decreased strength and slowed breathing. But if you lack the sheriff, like in hypomagnesemia, it's pure chaos in the saloon. You're looking at wild tremors, hyperactive reflexes, and dangerous cardiac arrhythmias. Let's just pause for a second to synthesize all of this. It helps to map out everything we just covered into a comprehensive matrix, from specific causes and dietary sources like nuts and green veg for magnesium or milk and dairy for calcium, to the distinct clinical manifestations for all 4 major electrolytes. Structuring the data this way is exactly what makes grasping these complex cellular concepts so much more efficient. Section 4, Medical Management. Now that we actually understand how this system works and how it breaks, let's explore the precise pharmaceutical tools and lab values that medical teams use to forcefully manipulate and monitor this equilibrium. To control fluid levels, medicine relies heavily on diuretics, but there are some absolutely critical nuances here. Thiazide and loop diuretics, like Lasix for example, work incredibly fast for rapid diuresis, but they are potassium wasting. That means you have to monitor the patient closely to avoid triggering cardiac arrhythmias. Potassium-sparing diuretics solve that exact problem by actively retaining potassium. And then you have osmotic diuretics like mannitol, which comes with a massive safety rule. It can form lethal crystals in the bloodstream if it gets cold, so it literally must be physically warmed up to room temperature before you give it. Oh, and because diuretics can cause hyperlipidemia, many of these patients are put on statins, which then requires active monitoring for liver damage. It's a whole chain reaction. Finally, we need to know if these interventions are actually working, right? We do that through essential lab values like hematocrit, BUN, creatinine, and specific gravity. The crucial takeaway here is how these exact numbers interact with each other. For instance, if you see an elevated BU1 paired with a completely normal creatinine and a highly concentrated urine-specific gravity, this points definitively towards severe dehydration rather than actual renal failure. It's like a puzzle telling the medical team exactly how to fix the fluid balance. We have covered an immense amount of ground in this explainer today, from the 70% of water trapped inside your cells to the literal life-saving rules of administering IV electrolytes. So I'm going to leave you with this provocative thought. The next time you hear a patient has a severe fluid shift or a sudden heart flutter, will you recognize when the internal sheriff leaves town before the biological scale irrevocably breaks? Applying these concepts and mnemonics to real-world scenarios is your key to mastering the incredible, dynamic complexities of human homeostasis. Keep learning, stay focused, and I'll catch you in the next explainer.